Bueno, ya estamos de regreso con el doctor Andrew Ibrahim para escuchar su conferencia. El doctor Andrew Ibrahim nos va a dar su conferencia en inglés, y si ustedes necesitan traducción, abajo en el menú van a tener un logo con un mundito. Clican ese logo y ahí aparece si necesitan inglés o español. ¿Ya? De esa manera van a poder acceder a la traducción simultánea. Modera esta sesión el doctor Pedro José López. El doctor Pedro José López, como ustedes lo conocen, es cirujano pediatra y urólogo pediatra, trabaja en el Hospital Ezequiel González Cortés, y él va a moderar la conferencia del doctor Ibrahim. Adelante, Pedro José.
Gracias, Sandra. Parto agradeciendo a la sociedad y al comité organizador la invitación a moderar esta charla que es bastante interesante. Andrew es un cirujano con estudios en diseño, con interés y estudios en arquitectura, y que se ha dedicado gran parte a tratar de combinar estos mundos del diseño, la arquitectura y la experiencia del paciente. Entonces hoy día vamos a ver su charla de cómo podemos ir relacionando eso, dejando las preguntas para el final por el chat, y yo se las voy a ir comentando cuando vayan apareciendo. Andrew, bienvenido a Chile, gracias por estar aquí con nosotros y te escuchamos.
Good morning. Well, thank you so much. It's great to be here. I'm taking on an ambitious challenge of talking a little bit about why I think surgeons should care about design and architecture and urban planning, and hopefully give you another way to think about the way we deliver care and how we might do it differently. There are a couple of my disclosures there. I live in 3 different worlds that are pretty unusual. Like most of you, I'm a practicing general surgeon. I operate every Monday. I'm in clinic every Tuesday. And every 5th week, I take emergency general surgery call for the hospital. So certainly that's probably my core identity of where I live the most. I'm a formally trained health services researcher. I have a master's degree in econometrics and measurement of quality. So think a lot about how to actually measure the care we deliver and how we may potentially do that better. And then before I did all that, I studied architecture. I did my foundation coursework at the Bartlett in London, and have been involved with architecture ever since. I'm currently a senior principal and chief medical officer of a firm called HOK, which is the 5th largest design firm in the world, that does a lot of interesting architecture work. And so getting to live across all these spaces, I try to bring them together to think about how we might redesign care. But let me tell you, my journey to that started much more closer to home. So I think a lot of us may remember the day we graduated medical school. For me now, a long time ago, but you start getting phone calls from all your family members asking you for medical advice. So sure enough, I got a call from my mother who said, you know, I'm having this pain. It's on the right side of my abdomen. It's worse after meals. And I immediately said, I think you need your gallbladder out. And she said, you're right. That's actually what the doctor said. And I, for a moment there, felt pretty good. I'd been a doctor for less than a day. And I thought, geez, I'm 100% correct on diagnoses now. This doctor thing is okay. But the next question she asked me really made me uncomfortable. She said, where should I go for surgery? Now, between where my mother lived and where I went to medical school was just a 30-minute drive. It was very close. However, there were 9 inpatient hospitals where you could get surgery. And if you haven't thought about the question, where you should go if you had to have surgery, it's worth thinking about pretty thoughtfully. So in our data in the United States, we've looked at comparing hospitals. In this graph here, this is rates of complications at centers of excellence. These are hospitals that meet all the best quality criteria. And you see there's tremendous variation from less than 1% to 14%. So it gives you pause to think, geez, where I go for surgery may really matter. And so how much does a hospital really matter? When I first thought about this, I thought about it through an architecture lens. And I thought, well, who has the best operating rooms, or where are things designed the best? So the most popular paper evaluating hospital design was published over 35 years ago in the journal Science, which of course is one of the most reputable, robust journals. And the title of it is Views Through a Window May Influence Recovery from Surgery. It evaluated 23 patients who underwent open cholecystectomy. And the rooms there in green were patient rooms that had a great window view. And the rooms in yellow basically looked into a wall. And they basically found that the patients who had a view of nature had less pain, required less pain medication, complained less, and went home earlier. This was a pretty provocative study at the time. And it has become a dominant theme in why we build so many windows in hospitals. It's been cited over 5,000 times. It's really hard to identify anything in our medical literature without a handful of studies that have been cited so often. But this has really been the dominant theme. But I think a lot of us, even if we're not formal researchers, could probably imagine that this isn't the most rigorous research study. It's only 23 patients. It's not randomized. There's no risk adjustment. And there's certainly opportunities to think more rigorously about the ways in which the hospital design may impact patients. So we've started to do that. We've laid out some formal frameworks for how to actually measure the quality of the hospital. And we've even gone so far as to take the blueprints of our hospital to code each of the design features, whether it's a single or double room, how far away it is from the nursing station, whether or not there's a direct line of sight that you can actually see into the room, and if they have a window view. And when you put those together, you start creating combinations where there are some rooms that have all the design features and some rooms that have some or none. I won't go into the details of this work now, except to say that I think we're at a unique moment where we as physicians can actually take our clinical data and look at these design features of the hospital as an exposure, the same way we would any other exposure, and test how well the design quality works. But let me get back to my mother. So I had no good recommendation for my mother, except to tell her that I thought she should come to the big academic hospital downtown. And, she pushed back and said, I don't really want to drive that far. The parking isn't very good. And she said, when I need a big heart operation, I'll go across town. So she had her operation locally at the hospital in her small suburb, and it went fine. And about a few months after that, this article came out in the New England Journal of Medicine that showed nearly twofold variation in inpatient mortality after surgery. And my gut sank. I thought, oh my goodness, did I let my mother go to the wrong hospital? Even though she did fine, I was so worried that did I put my mom at undue risk? So I started reading these articles very closely. And what is important about this work, almost all of these papers that show bigger hospitals are better look at procedures that have a death rate of more than 1%. In other words, they're high-risk procedures. So when I went back through all the other literature, it turns out they were all looking only at complex procedures. But I wanted to know, what about for common operations? What about for the things that we get all the time, appendicitis, cholecystitis? Is it safe to stay local, or do you have to travel across town? Because the answer to that has some real urban planning and design implications. And so I wanted to understand that as a surgeon who does these operations. So when I went to my mentor at the time, Dr. Justin Dimmick, he often would say he's not an architect because I would always bring him these design questions. But he did say, but I can teach you how to evaluate quality of care by location. So we identified about 1,000 rural hospitals that had critical access designation. Critical access designation in the United States is very specific to hospitals that are less than 25 beds and more than 35 miles away from another hospital. These hospitals are considered essential to maintaining access for surgical care, and they are subsidized by the government to an amount of more than $9 billion annually. So I wanted to know, how well do these hospitals perform for common operations? So we evaluated that, and we looked at 4 common procedures done by general surgeons using 1.6 million Medicare beneficiaries, which is our major government insurance in the United States. And we basically found that the small rural hospitals who are doing these procedures often at lower volume are able to do it at the same quality, same or better quality. So they had no difference in mortality rates, and in fact, lower complications. Kind of counterintuitive to the common way that we had been talking about referrals and where to send patients, that these small rural hospitals are actually doing quite well. And the next question, if you talk about healthcare anytime in the United States, but how much do they cost? We're subsidizing these hospitals with a lot of money. Are they actually costing us more money? Turns out the answer is no. These small rural hospitals are actually performing these common procedures at similar quality and lower cost, which kind of creates a very interesting counterintuitive finding that maybe for these common route operations, we should be advocating that patients stay close to home. So this paper is published in JAMA, and within 2 weeks became the 49th most shared article in their network out of 20,000 publications at the time, which certainly we were really proud of our research group for being able to do work that had that kind of impact. But it meant 2 things. One is it certainly got the communities with rural hospitals very excited, and the rural health associations said, Andrew, will you come talk to us at our national meeting? And I said, of course, I'd love to. But the second set of emails that I got were from investors, and I was very confused by that. And they said, Andrew, you told us that these hospitals provide the same quality of care for less money, which to us means value. So are you suggesting that we should buy these hospitals as an investment? I honestly had never intended the work to be used that way and never thought about it that way. But it certainly was a researchable question and something of interest. And what they basically were asking is, you have all these small and large hospitals who clearly do things better than others. Some hospitals are better at this procedure, some are better at this one. And the question is, where's the value? And if you connected the hospitals to each other, could you take advantage of that? Could you strategically create networks where the hospitals with different strengths and specialty priorities could function together and improve care overall? And so sure enough, over the last 10 years, the rate of hospitals forming into networks has more than doubled. In the United States annually, there are more than 100 hospitals who join a network. that roughly is about 2 hospitals every week in the United States join a hospital network. And so this question became much more relevant of understanding, well, how well does a network perform when they join together? So my mother is now at this point much cooler, and she doesn't call me anymore. She has learned from my nieces and nephews that text messaging is the way to go. So she texted me and said, "Hi, Andy." I said, "Hi, Mom, what's up? Aren't you a surgeon now?" I said, "Yes." And she said, "Right, I told my friends. And aren't you a health services researcher too?" Which is what I'd spent my 2-year master's degree studying. And I said, "Great, yes, I am." And she said, "Good, because they all need surgery. So you need to recommend a place for all of them." And I thought that was actually such a great way to capture what a health services researcher tries to do. In other words, I wasn't just coming up with a recommendation for what a single person or a family member should do. It was now trying to think for an entire population, how should we think about which patient should go where to get the best care? And in other words, sort of redesign the way we organize our delivery system. So now the question sort of changed from, instead of designing a single hospital or a single operating room or a single floor, it was now really about how do you optimize networks and a whole collection of hospitals and their relationships together. So we started to look at how well do networks perform in relations to themselves. So this graph here is rates of complications after surgery. Each dot is an individual hospital, and dots that are in the same column are in the same network. So let me point out a couple examples. This hospital network here has about 5 hospitals, and they all have fairly low complication rates, high quality, and they all perform very similarly. In contrast, this hospital network has about 30 hospitals, and some of them perform very well. Their complication rates are as low as 5%, but others of them are over 30%. Yet these hospitals are all part of the same network, all share the same name, but perform wildly differently. And so I was very interested, could you take a hospital network that looks a lot like these in the red bar and transform it to this green bar? Can you get hospitals who are very different, but now join each other as a network to now become more similar to each other and have higher quality? So I think there is some evidence from the literature about how to do that. So one strategy is send as many patients as you can to the main hospital. And I think for complex operations, that makes a lot of sense. This landmark paper from 2002, now 20 years old, has reproduced itself over time, that for complex operations like pancreas resection, esophagectomy, the higher your volume, the lower your complication rates. And there's even been efforts in the United States now to have volume pledges where hospitals say they will only do these operations if they do a certain number per year. In other words, it's trying to take advantage of this literature to have patients go to hospitals where they might get the best care. And I told you on the other extreme, there's probably hospitals or procedures where it's safe to stay local, appendectomy, cholecystectomy, that you may not need to go to a large specialty center. But what about everything else? What about the things in between that aren't common low-risk operations or rare, very extreme high-risk operations? What about everything in the middle? So I've been trying to study that for a number of years now. And I've spent a lot of time studying hospital networks. So I want to tell you about one and some of the lessons I learned from them about how they redesigned their delivery system. And it's called Carolinas Health System. It's in North Carolina. It's about 2 or 3 hours south of Washington, D.C. And they have about 200 clinical sites that span over 3 states. And what caught my attention is their motto is uniform high quality care anywhere in the network, which, as you saw from the previous data, that is quite a challenge to have care at multiple sites and say that they all deliver similar quality care. So I went to study them and I learned a lot of things. They had 4 strategies that they used to improve the way they deliver specialty care. And in this case, it was cancer care in this example. And the first was to disseminate their knowledge expertise. When they formed into a network, they realized, gosh, some people here are very good at lung cancer, and some people here are very good at liver cancer. And they said, what if we could standardize our knowledge across our network? And so the way they did it was they actually built it into the electronic medical record. So in their health system, when you went to give a patient a diagnosis of, in this example, non-small cell lung cancer, it would then tell you what the first line workup ought to be. It'll then tell you what the treatment options are based on what is preferred and what might be an alternative, either based on the patient's allergies or what is locally available to them. And then it told you what the follow-up should be. In other words, any patient in the network who had this diagnosis could get a uniform quality in terms of workup, in terms of treatment hierarchy, and in terms of follow-up. So for many people who maybe don't see in their network providers who don't see the conditions as often, they were able to get at least a standardized framework or guideline for how to use care right within the medical record. So the next was they changed the way where they built their clinical sites. So they were largely consolidated around one big urban area and were at capacity. And they said, you know, should we just build another hospital right next to the main one where our current hospital is? Instead, they went the opposite direction. They built 3 different sites that were far away from their main campus to help improve access and spread out care of their experts. Third, they spent a lot of time investing in care coordination. So they realized that in cancer care, there may be multiple providers at different sites who all need to weigh in on your care. And I think that's probably similar for pediatric surgery care, especially in specialty care, where you may need the input of a handful of specialists who may not be available at your site specifically. And so they spent a lot of time investing in telehealth and tumor boards that were done virtually so that providers across multiple sites of care could all weigh in on that same patient without the patient having to travel to multiple sites. And then finally, they spent a lot of time in building a collaborative culture. So that example I showed you before, you may have a patient with that diagnosis who doesn't fit this treatment algorithm that was put together by one of the experts in the network based on best guidelines. But at the bottom here, they had a button that I call like a phone a friend, that basically if your patient didn't fit this care pathway, you could click on this button and it would connect you to the expert who developed the guideline, who would know the most about that condition, who could then help you figure out, how does that work? How should it work for this patient? Do they need to be referred now to a bigger center? Or are there things differently I can do locally that aren't on this protocol? So I think there are complementary strategies, especially for surgical care. There are some technical things where we really need to centralize procedures. And there are some opportunities where we can spread out our knowledge expertise, where the patient may not need to travel, but we can still provide them high quality specialty care. So we've written that up, and I'm happy to share this article with anyone who's interested. I'll leave my email at the end and can send it to you. And so what does it mean to be a larger network? So in the United States, the reality is for us, there is no longer a single hospital anymore. 80% of hospitals now belong to a network. And the average size of a network is anywhere from 10 to 15 hospitals who now all have to coordinate care. And so that has sort of changed the way hospital systems and networks are thought of. So the US News and World Report every year puts out rankings of the best hospitals in the United States. And these are watched very closely and taken very seriously. And in light of the hospitals all forming in the networks, the US News and World Report wanted to change the way they evaluate hospitals. So in their definitions, they've expressed these ideas that rather than seeing a provider as a hospital contained within 4 walls, we envision a web of hospitals of varied sizes and functions within an ecosystem that can work on things like population health management that benefit whole communities. What a big shift from the way we thought about hospitals even 10 years ago, that rather than a single place of care, you're now an ecosystem of multiple sites, and you need to have some responsibility to the community because of how big your network has gotten. So there are a number of insurance groups and government agencies who have been very interested in, should the hospital, now that it's gotten so big, more directly address things in the community. So there's been pilots of something called accountable health communities, which essentially tries to connect hospitals to their communities in ways that should influence their health. So these are the 5 domains that this pilot initiative asked hospitals to focus on. And they're housing, food, utilities, safety, and transportation. And these are things that obviously I don't think we normally get taught about in medical school, but I think if you thought about them, you could certainly imagine how a detriment in one of these could certainly impact a patient's health or their ability to access the healthcare system. And so it was quite novel for policymakers and insurers to say, hospitals should have these things on their radar and should pay attention to them because they're so important to health. So they started to create tools for clinicians in the office to start asking patients about things like, what is your housing situation today? And do any of these things apply to you that may affect the quality of your health in your home, such as lead paint exposure, having inadequate heat, or non-working smoke detectors, or water leaks, things that clearly impact health. But now it's being asked that clinical providers in the hospital ask patients about these to try to connect them to resources. So it has gone on scale. Most health insurance groups in the United States are now investing in better housing. And what they've started to realize is that patients who have poor housing utilize the healthcare system more and are costing the system more money. So could we spend some of that money on better housing? And if that prevents people from using the health system more, that actually saves us money. It's not to say that these ideas are totally new. These ideas have certainly been around for a long time. But the idea that a healthcare network and an insurance company is going to explicitly pay for it is very new. It's also gone into food access. Health insurers have now started to think about ways that they should improve access to healthy food, whether it's healthier grocery stores or providing plans where it's easier for patients to get healthier food as a way to try to be accountable to the communities they're in, but also as a cost-saving strategy that it may reduce the amount of time patients use healthcare resources. So in the architecture world, this is the American Institute of Architects, is the AIA. We've also thought about it from our end of what can architects do and think about that could influence the health of patients in their community every day. And the probably most popular quote in this group came from the US Surgeon General at the time that really advocated we should think about architects as public health workers. And again, it's not to say that there weren't any connections to architecture and health before, but to explicitly say that if you're an architect, you should think of yourself as someone who influences health. In the same way now that the people in healthcare should be thinking about how do we influence the built environment. There are long roots for this. Marcus Vitruvius, who's thought to be one of founding fathers of architecture, who you may know, Da Vinci painted his Vitruvius Man that takes the proportions of a man to inform proportions of good architecture, wrote in his earliest canons, the architect should be equipped with knowledge of medicine, for without these conditions, the healthiness of design cannot be reassured. So in the United States, people, when I give this talk, say, you know, we're already spending too much money on healthcare. It's 15 to 18% of our total budget. But I'm more inclined to think about how are we spending the other 80%? When we think about roads and housing and transportation, are we thinking about those with health as a priority? Are we thinking broader than just the hospital one building, but to think about how do we influence what we're designing and building for health more broadly? And so I've been very interested in this idea of health in all design, that everything we build and design could be done with health as a priority. So I gave this talk in London now almost 3 years ago and proposed the idea of health in all design. And in one of the examples, I said, wouldn't it be great that these giant football stadiums that we build that can fit 100,000 people, that can feed 100,000 people in just a couple hours, wouldn't it be great if instead of designing these stadiums just as an entertainment venue that get used a dozen days a year, could they be a resource for the community that's used to improve their health every single day? Now, when I said that initially, I thought of it being almost like a giant public park. Little did I realize that a pandemic would happen a year later, and that in fact, our stadium, because it was so large, had so many resources and knew how to get people moving through the space so efficiently, actually became the primary site for COVID vaccinations. Within just a few weeks, we had 15,000 people get vaccinated there. So it's quite interesting to think that the structures we're designing that have all these great attributes may actually be very vital to the way that we think about health and healthcare delivery, and that these relationships should be connected more explicitly. So for a long time in the US, when you asked about what should the future of healthcare look like, in 2000, everybody said, you know, avoid never events, avoid big complications. In 2010, people talked about, let's try to save money and pay for things in bundles. But I think the era that we're in and that we're moving towards is there's a lot of interest for health upstream. So before you get to the hospital, what are the ways that we can improve and influence your health? And what are the ways that networks really matter? What are the ways that we take advantage of all the expertise that we have individually, but also as a group, and how do we organize those relationships to be better? So I think for us as surgeons, there are probably 3 opportunities that I think we should really think about and really take to heart in terms of ways that we should engage with design. I think the first is in hospital design. I showed you that research paper from 30 years ago. There are a number of questions that are unanswered about how does the design of the physical hospital improve health. And it's not to say that architects are not interested in those questions, but they don't have the expertise that we have to think about, well, where should an operating room go? How much does a pediatric ICU matter to have these resources, or the distance from the nursing station? They really need our input to understand better design, but they also need our research understanding. Many of us, just by being in clinical medicine, can read a research paper and understand different methodologies, understand if those findings make sense and should apply to this group or not. That is not very common in architecture. And so I think collaborating in that way would be very fruitful. I think the next space that surgeons, we should really be active in is thinking about how we redesign hospital networks. It is very clear, I think a lot of us in surgery would understand that for some procedures, the hospital you go to may be very important, and it may be based on the procedure type. It may be based on the resources available. And there'd be other procedures where those things are less important, but we need to come up with ways to design those systems and networks so that their relationships are optimal and that they're working the best they can. And it's both a design question about how do you actually build these number of hospitals and these relationships, but it's also a really important clinical and research question about improving outcomes for patients on a population level. And then finally, thinking about neighborhoods. I think 10 years ago, if I went to our national surgery meeting and said, I want to speak for an hour about the way surgeons should be engaging neighborhood design, I think a lot of us, I probably would get not put on the program. It probably wouldn't be a very popular topic. But now I think it's becoming very clear that because health systems have gotten so big, we are a part of the community. We do have a presence there, and we do have a relationship with the community that we should optimize. And so I'm excited specifically to be in this pediatric surgery group, because I think pediatric surgeons within the context of surgeons have probably been the most interested and the most aware of where a childhood lives, their home and their neighborhood, how that influences their ability to be healthy. And so I think it would be great if surgeons were more active in taking our experiences from what we see in our clinics, from how we see people recover after surgery when they go home, and engage with urban planners and say, what would a healthier neighborhood look like? And use some of our expertise to help inform that. I want to leave you with a quote from someone who is kind of one of my heroes. His name's Ernest Codman. He was a surgeon in the United States in the late 1800s who pioneered the idea that any operation that we do, any treatment we provide, we should follow the patient long enough to know, did that treatment or procedure work? And if not, why not? So that we can prevent that problem from happening again. His idea was so revolutionary at that time, and is now only in the last 30 or 40 years become normal culture for us. But I would love if not only this quote, I think rings true with many of us in clinical surgery, I would love if it also applied to architecture and design. And I think if Codman was here and got a chance to talk with architects and designers, he may say something like this: the common sense notion that every hospital architect should follow the hospital they build long enough to determine whether or not the hospital has been successful, and then to inquire, if not, why not, with a view of preventing similar failures in the future. In other words, that we should take the same spirit of quality improvement and measurement that we have towards our procedures, towards our medication decisions, that we should apply that to the built environment, whether it is our hospitals, our networks of hospitals, or our neighborhoods at large, that we have a chance to do that. So thank you again for your time. There are a lot of people behind this great work. This is just a sampling of a lot of the people whose work I just featured on my research team. And I will say thank you. This is our stadium here in Michigan. So hopefully post-pandemic, if any of you do get to Michigan, I will be excited to come take you to a football game. And with that, I will save some time for questions. And if I don't get a chance to answer your question during this moderation session, my email is there and I'd be thrilled to follow up with you afterwards. Thank you.
Muchas gracias, Andrew. Muy interesante la charla, cómo vas uniendo distintos conceptos. Y tenemos un par de preguntas, estoy seguro que van a ir saliendo más preguntas por ahí. Vamos a dividir los temas y las preguntas igual como tú dividiste tu presentación. Partamos por las redes y cómo construir redes. ¿Cómo defines, para partir, las cirugías que son más complejas o habituales y de las no habituales? ¿Cómo fue esa división que hicieron? Es una pregunta de Sandra Monteónico.
Great question, and thank you for that. There are different ways to think about it. I think the two criteria that inform that decision is, one, what are the complication rates of the procedure? If a procedure has very low complication rates, such as maybe an inguinal hernia repair or an appendectomy, I would put that in low complication, as opposed to, say, a Whipple or an esophagectomy that has high complications. So one is sort of the complication rates, and we would know that just objectively by numbers where procedures fall on the spectrum. And then the second criteria is, how often is it performed? So if it is a procedure that's done only a handful of times a year, that's quite rare. If it's a procedure that we do every day, that's common. And so I think the combination of complexity and how often we do the procedure inform how it fits into a network model.
¿Y el porcentaje de reintervenciones es parte de esa ecuación para saber cuáles son habituales y cuáles no son habituales?
Yeah, exactly. So I think within the complication rates, I think it would include things like reoperation or reintervention rates, rehospitalizations. How often do you have to get readmitted and come back to the hospital? I think there's probably a broader category of what defines that, but exactly right. I think reinterventions and reoperations is important.
Y con esa tasa de reintervenciones, de las que no son habituales, ¿cómo saber o cómo dividir los lugares, los hospitales, que son hospitales con mejor performance que otros, que pueden ser base para hacer esta red?
It's a very good question. I'll tell you some things that people have tried with some varying success. So bariatric surgery in the United States, when it was becoming popular, had very high complication rates. Mortality initially was 5 to 6% within 30 days of surgery. And so there was this big push for centers of excellence to say that to do this operation, you should meet these criteria. What ended up happening over time is actually the procedure got safer and everybody got better. And so the difference between the hospitals who met all these criteria and the ones that didn't was very small. And so the center of excellence idea actually became less important because everybody improved over time. I think there are procedures that are rare enough that volume is probably our best predictor, how many you do per year in terms of identifying a center. But I think it is very procedure specific and still some debate about how do you identify the best qualities or the best resources that make the best place for referral.
Y si eso lo unimos, Andrew, con entrenamiento, con cómo vamos a formar cirujanos infantiles en este caso. A medida que tenemos patología más compleja, es patología menos frecuente. Y me imagino, si lo ponemos en una pirámide, todas tus cirugías habituales están a base de la pirámide por baja tasa de complicación, por alta frecuencia de hacerlo y porque más personas lo hacen. ¿Cómo impacta esto en tu formación de cirujanos?
Yeah, it creates, pediatric surgery has a very unique circumstance because your volumes are generally lower. So one thing that has started to happen here, and I'd be curious if it's true in Chile as well, is within a group of, say, 5 pediatric surgeons in a hospital, anytime a colon operation comes up, it may go to one specific surgeon who develops specific expertise in the colon operations, and another one for thyroid operations. They're not necessarily fellowships. It's not as if there's a formal pediatric surgery colorectal fellowship, but within groups, they have informally sort of done that. And so I think one of the things that maybe we think about in training that may be particularly relevant to pediatric surgery is not just fellowship, no fellowship, but is there something in between to say, look, this isn't a full year formal fellowship, but should you spend 2 or 3 months of time at a place that does this very often to build this extra specific skill set to bring back to your group? And so I think it's a work in progress, but I think the idea of, in the same way we need different levels of complexity provide care, our training should mirror that to full-fledged complex fellowships, to maybe mini fellowships, to maybe week-long courses, and I actually think pediatric surgery internationally has been a leader in that, with a lot of the international courses that are being done to get surgeons sharing technique. And so I think somewhere in between a full fellowship and sharing technique is an opportunity to build up some unique expertise.
Para ir terminando un poco con las complicaciones y eso. La tasa de complicaciones se mide por cirujano, por equipo, por hospital, por la red. Es una pregunta de José Campo. ¿Y cómo definen una tasa aceptable de complicaciones? ¿Quién la define? ¿El Sistema Nacional de Salud? ¿Las aseguradoras?
Good question. There is a conceptual answer and there is a methodologic or practical answer. Let me give you the methodologic practical answer first. If, let's say, Andrew as a surgeon only does a procedure 2 times a year and I have 1 complication, saying that I have a 50% complication rate is probably not a good measure. It's probably not reliable. I may have just been unlucky. Or similarly, if I had no complications, but I only treated 2 patients with that condition, I may have also gotten lucky, and saying I'm a 0% complication surgeon is probably unrealistic. So I think from a methods perspective, there's a minimum volume of procedures that have to be done to say this is a reliable measure. And so I think surgeon level measures are very difficult. because our volumes aren't often high enough. So it tends to go to hospital. How much does your hospital perform that procedure as a group? And that, just from a statistical perspective, gives you enough volume to start to measure it. So that's like a practical answer. From a conceptual perspective, there are definitions for 30-day complication rates that are pretty standardized in the United States. And I think most people would say that 0% complications is unrealistic, and that may be a wrong way to think about it. I think what people are more interested in is if you look at everybody who does that procedure, all the hospitals, and the average is here, whatever it is, that may be an appropriate or expected complication rate. But who are the hospitals that are very far outliers? So in a sense, it's a empiric judgment of how far away a hospital is from what is average to identify too high of complication rates. But it's certainly a judgment call. There are some specialty societies who've made kind of consensus guidelines about what should be a complication or what shouldn't. There are some things that are not debatable, like death within 30 days of surgery. I think most people would say that's a complication that should be counted and measured. But in contrast, what about a readmission? If a patient goes home and they're not doing well and they need to come back 3 or 4 days later, is that a bad thing? It may actually be a sign of good care that the surgeon's very diligent in following them closely. So I think there are some measures that are less controversial that people accept, and some where there's some judgment calls that maybe the amount is appropriate.
Gracias, Andrew. Yendo un poco a los diseños de los centros y los hubs que tú muestras, me imagino que hubo resistencias de gente, lo que llaman tus investigadores los stakeholders, gente que no quiso perder o ceder espacios. ¿Cómo manejaron eso? ¿Cómo se maneja el que se construya un centro de derivación donde estamos mirando la experiencia del paciente más que el beneficio personal?
Yeah, that's a great question, and very insightful to identify that. So I think if you thought about it as an individual person, why the heck would I give up these procedures? Why do I trust whoever an hour away who says they can do it better? So I think part of what is essential about the conversation of referrals and networks is at the beginning, there should be an understanding that within this whole network, there must be some people who do things better than others. There must be somebody who can do a liver resection better than me. And there may be things that I can do better than other surgeons. And so I think at a starting point, there needs to be an acknowledgement that everybody has value, everybody has different types of expertise, and that we should be connecting the patient's complexity of problem to the surgeon's level of expertise. So I think of it like matchmaking, not as much as taking patients away or giving patients to, but in a sense, matchmaking the right level of complexity to the right level of surgeon expertise. And I think practically, the only way that maybe works is if the surgeons have a shared interest. So if you're an individual hospital, you may not want to give up any patients, even if you don't have the expertise. But if you are in a partnership with another hospital because you share the same network, the same system, the same government organization, the same insurance company, you have some relationship that connects you, you now may be more willing to say, okay, we'll do these procedures and you guys do those, and focus our expertise because we have a shared relationship and common interest.
Siguiendo esa línea de pensamiento, hay operativos quirúrgicos que van a países en vías de desarrollo. El Club de Leones trae los oftalmólogos a Chile y hacen grandes operativos. José Campos pregunta, ¿qué opinión tienes tú con relación a que traigamos cirujanos a centros que no están a lo mejor cualificados, y estamos, y con esto lo relaciono con una pregunta que tiene Juan Pablo Valdivieso, con listas de espera, en que el acceso a los centros, al menos en Chile, puede no ser tan óptimo como el gran hub que tú describes en eso?
Yeah, I love that question because I think about it a lot. You know, in the United States, we have 300 million people, but 80 million live in rural populations where they're more than an hour away from a hospital, which is quite remarkable to think that in the United States, almost a third of our population is more than an hour away from the hospital. And so I think there's some considerations about this model of, so the surgeon who's maybe at this main center, they go out to this rural population to improve access 1 day a week, 1 day a month, et cetera. I think there's sort of two questions to think about that. One is the expertise needed just the day of surgery, or is the expertise needed also after surgery? In other words, so in ophthalmology, I think there's some good examples where the expertise is on the day of surgery. And so it makes a lot of sense for the surgeon to go there. However, when I think about something like a Whipple, which the expertise is both the day of surgery, but also in the recovery. Because if you have a complication or a pancreatic leak 5 or 6 days after surgery, you need an intervention team nearby to put a drain in, maybe go back to the operating room. And so I think in the model that you proposed, I think it just needs to be the right procedures where we know that the expertise needed is limited to the day of procedure and not necessarily after, or if there are things after the procedure that could be done remotely. So for example, knee and hip replacements in older adults. The expertise is really the day of surgery, and you may be able to follow the patient remotely through their rehab, through their other treatments, or have other experts locally do that part of the care separate from the surgeon being there. So I think it's just choosing the right procedures, but I think it's a great model to consider and try to implement in the goal of improving access.
Nos quedan pocos minutos y no quiero perder la oportunidad de explotar tu lado de arquitectura y de diseño. ¿Cuánto deberíamos estar involucrados los cirujanos en el diseño de un hospital y en el diseño de la experiencia de un paciente que pasa por un hospital?
Yeah, great question. So I'll tell you what typically happens and what I would love to see happen. So what typically happens is there's a decision, we're going to build this new hospital, this new clinic, etc. And everybody gets very excited. There's fundraisers, there's ribbon cutting, the architect gets hired, all this excitement. And they come to the surgeons like you, Pedro, and they say, Pedro, tell me your ideal hospital. And you give all these brilliant ideas, they write them all down, and then they never talk to you again. And the next week, the city code person comes in and says, this won't meet regulations. And then the next week, the engineers come in and say, not feasible to build the walls this way. Then the next week, someone else comes in and says, we need to save money, we can't do all those things. And over time, 10 or 12 other groups of people besides the clinicians will change the design to the point that by the time the hospital gets built, you look at it and say, that's not what I recommended. That's so far away. And so I think part of the challenge is, how do you keep the clinicians involved throughout the process? And so our time is so valuable and it's hard to get a hold of us. But I've gone so far from the architect perspective of putting scrubs on, meeting surgeons in the operating room to ask them follow-up questions as we're further down and say, you know, you recommended this idea. We've gotten these other complaints or other competing interests that we now need to accommodate. What do you think? And so I think ways to stay involved throughout the process would ultimately lead to a better design. And your point about patients is well taken. It would be great if both the clinical provider and patient are reinserting themselves every month or every 3 months in the process so that their focus isn't left behind.
Gracias, Andrew. Con esto termino. Andrea Contreras nos pregunta si tú sabes de algún estudio de posgrado, algún fellow, en que pueda combinar diseño de hospitales, experiencia de servicio, arquitectura, medicina, algo donde podamos ir combinando esto y no hacer 3, 4 estudios separados.
I love the question. So we last year started a health and design fellowship that takes practicing architects and we formally train them in healthcare research using econometrics and healthcare public health science to engage them so that they know a lot of the things that we think about all the time. So we only started it a year ago, but I'm optimistic that we can continue it and grow it so that there is more common ground, both on the architecture and clinician side, to fill some of these knowledge gaps. So I don't know if intentional, but thank you for asking, because we do have a great fellowship and it's on my website. If you want to find out more about it, it would be great to include you guys somehow in the process.
Muchas gracias, Andrew. Fue una excelente charla que nos saca un poco el pensamiento habitual que tenemos como cirujanos. Y con esto estamos cerrando nuestra charla magistral del día de hoy. Así que le agradezco por las preguntas y por el tiempo. Agradezco de nuevo la oportunidad de moderar esto. Sandra, la cámara es toda tuya.
Muchas gracias. Muchas gracias, doctor Ibrahim, por su charla. Como decía el doctor López, ha sido una charla que nos inspira a reflexionar en otros ámbitos, así que le agradecemos por la oportunidad de escucharlo. Doctor López, muchas gracias por su moderación.